Thank you for joining me this morning. I'm going to be doing double feature. We're going to start off with talking about the ICam workflow and how that works from start to finish. Basically, the idea is that for this segment, I'm going to be going over how digital workflows actually allows us to work with just about anyone we want. And we can easily swap out the different stakeholders involved beside the patient in order to achieve the ideal outcome. So why am I doing all this, and why are we all interested in digital workflows? Biggest thing is, okay, how do we make the patient experience better and more predictable, and how do we improve upon issues we've had in the past? So before I move forward, this is one of the biggest things I personally struggle with as a prosthetist in private practice. A lot of times, patients don't actually understand what we're trying to accomplish, and it's very difficult to manage everything from start to finish. So whenever people ask me what I do for a living, I always tell them I solve problems people don't know they have in ways that they won't understand. And part of this is true, and part of it is also very tongue-in-cheek, because the reality is that I'm the puppet master behind everything that's going on in an all-on-4 surgery. So I am actually not a surgeon myself most of the time. I manage all the data, and I manage all the people surrounding the scenario. So with the advent of advances in digital dentistry and also what we can do with it, what I've done over time since I started doing photogrammetry about 2018 is that what I realized is that with the ability to basically design everything digitally and rapidly manufacture everything really quickly, we can compensate for some of the shortcomings we've had historically related to full arch. We want to minimize the number of potential complications because reality is in private practice, complications are costly to us. Other is that we now have better materials and manufacturing methods. We're making the all-on-4 workflow more accessible to everyone around us. Because what's going on is that now we don't need to have necessarily a local lab if you have your own ICam, or if you do have a local lab or multiple local labs to choose from, now you can actually kind of pick and choose how you want to go about things more rapidly and more efficiently. When it comes to the stakeholders involved in any kind of interdisciplinary treatment, we're dealing with the patient front and foremost, but usually when you look at all the other people involved in making sure that they make it from start to finish, you have the restorative dentist and then you have the surgeon, sometimes the same, and the lab technician is the most removed. The problem with this is that how do we best communicate what's going on in the patient to the technician? And that's a problem we've been trying to solve in all-on-4 workflows for as long as it's existed, right? So basically what's going on is I'm going to start off by showing you the hybrid conventional digital workflow. So this is how things used to be for me. I would have the lab digitally design a set of denture teeth, and then from there, do a chairside pickup, and then finish converting it. And then eventually, when the patient heals, I still have to do a final impression, go through the entire workup again before we go to the finish. And guess what? At the end, we have to deal with maintenance, and heaven forbid that you don't have great control of sintering shrinkage. We have fractures, and we have other maintenance issues that may bubble up over time. When you look at how everything comes together, you look at the technical variables involved and the amount of errors that can be induced along the way. It's no wonder that sometimes when you send things to the lab, things come back not quite as expected. How many people in this room has ever had to argue with their lab over their outcome? How many times have you sent denture setup back to move the midline a millimeter? How long does it take the technician to move that midline by a millimeter? Is another great question, and maybe that's why we get the blowback. So just by looking at this huge list of different things where it's either a technical issue on the clinical side or how we even take our photographs, suddenly our communication clearly cannot be that straightforward. So when you're looking at a traditional or conventional workflow, more or less, we're looking at over 13 visits. Total chair time is over 10 hours. Number of lab communications, more than 4. And the potential errors at this point is infinite because the lab will send things back when they're ready, right? And lastly, the commitment to the patient is infinity plus 1 because in pros, we marry every patient we meet. They're ours forever until one of us dies or retires. So when we compare side by side a fully digital workflow to the conventional digital workflow, this is what it looks like for me now. I went from 13 visits to less than 6. Chair time is about 30–40% less. Number of lab communications still stays about the same, but we can actually trace where things happened, because we can go back and look at each design and go, what happened here? How can we improve upon it? Meanwhile, within the conventional workflow, they're still subject to way more variable. And at the very end of it all, we're still fully committed to the patient to ensuring that they have the best outcome possible. If we were to look at papers where they followed patients over decades, and this is one of my favorite papers to reference from the Malo Clinic, they followed over 400 patients, or tried to at least. And what happened in the end is that you see that biological issues were actually not that serious. Like, they had them happen, but the percentage of occurrence is quite low. However, what you'll see here is that regardless of the type of implant placed, where the implants are placed, they had a full workflow dialed in so that you would see that maybe the surgeries went consistently and the restorations were also inserted a certain way and very consistently designed a certain way because they're all from the same labs. So what happens at the end of all this is that you see the biologic problems that occur, which is low. What happened is that the biggest complication they experienced was in prosthetics. And it's all related to acrylic. How many of you have had to deal with fractured acrylic on a patient? What do you do then? How much chair time does that cost you? So acrylic issues are actually the most common complication. And after that was screw loosening. Screw loosening, okay, we tightened the screw to 15 newtons. So, I mean, it could happen. So what I want you to think about is how much chair time and how much can you charge out to the patient and how much of these lab fees will cost you if the patient says, oh yeah, I was just eating tofu and this happened. If the lab were to remill it for you, how much would that cost you? Or if you tried to put Humpty Dumpty back together in the chair, how much time would that cost you? Or what if you had one of the conventional acrylic titanium prostheses, and after maybe even just 2 weeks in function, or 2 years in function, they wind up with fractured acrylic. Can you even match that denture tooth back? How many visits would that take? So these are all complications that I was confronting in private practice, and what drove me to digitizing things, because it made remakes easier, faster, and more cost-effective. So every time I brought in another digital technology into the workflow, I always ask myself, is this making things better, faster, and more predictable? And the answer is, let's go fully digital and minimize the number of moving components. So the answer is to minimize the number and magnitude of potential errors, and that's all we can do. And that's how we can always improve. So if you were to look at just fabricating an all-on-4 type prosthesis, this is the cumulative errors that can occur over time. What you'll see is that even if you had the perfect impression poured, what if your technician was really ham-handed and didn't make sure all the analogs were seated, or maybe they're really upset at you and poured up the stone and just slammed it onto the bench top? Will that move your components or change your impression even if the PVS is perfect? Totally, right? Or what if they decided that they wanted to pour it in Daikin, which is a type 5, or not type 5, but it's a very large expansion stone? What will happen there? So when you look at master cast, there's a lot of variation. And then when you look at 3D printing versus centralized milling, that induces another layer. And then whenever you need to put in a tie base, how much space does your technician budget in order to make sure that it will seat in your restoration when it's sintered? And how does that differ from a crown? So basically, you're adding another layer. And this is what we're looking at when we add additional components and also change up our approach to all-on-4 prostheses. So for all intents and purposes, I'm going to going over the workflow at ICam today. You're going to see a lot of different types of photogrammetry on the market now. What makes ICam a little bit different is that it has 4 cameras. And they have titanium scan bodies, which not every system does. So this is very important to note. If you're going, okay, well, if I'm going to just do photogrammetry, what proof is there that it works better or faster? The reality is that if you're really, really good at making a conventional impression and really, really good at minimizing the errors that are involved in pouring up an impression, it's comparable to doing an ICam scan or a photogrammetry scan. So I'm not here to tell you that if you're already making great PVS impressions, this is going to be better. But what it does is make things more consistent. So what you'll find in paper after paper is that extraoral scans are generally less technique sensitive than conventional impressions. So from a private practice standpoint, this means that you can hand off the procedure to an auxiliary to help you or have someone else do it instead of you. And lastly, it's consistent despite the number of implants, implant angulation, and AP spread in most clinical scenarios. I'm not going to say all, because I can tell you there are some where it might not work that well, and it's because the camera can't see the scan flags. So with the advancements in digital dentistry workflows, all stakeholders do not need to be local, but they can be. Because what happens is that, guess what? If, say, you have an ICam and you decide to do the full arch scan, you can send that data to just about anyone who knows how to process it. And that was one of the biggest game changers for me, because that means when I moved from LA to Seattle, I could continue sending data back to the lab I originally worked with and not miss a beat in terms of timeline, because I no longer have shipping fees. I just have to make sure it's in Dropbox and they got my info. So when it comes to communication with labs, if they don't have to be local anymore, we just need to make sure we have really good digital data, from scanning to photography, and making sure that we have software that allows us to best communicate with the technicians we're working with, and in my case, we're also communicate with the surgeons as to where the implants need to go. So if we look at all this is actually all under the Nobel family in terms of product line, and I'm going to show you how it all comes together. So this is the part that I really wanted to get to, which is the 2-visit immediate loading clinical workflow. Visit 1. The entire focus is on making sure that the patient's the right candidate, you get all the technical data put together, and send it off for a digital wax-up and start surgical planning. Visit 2 is where you start with a surgery, then you do the digital conversion, and either the lab or the clinic can print the restoration, depending on who has the printer, and you finish, insert and adjust. So on this level, it looks a lot like the conventional workflow. However, when you look at the time assigned to each step, you're saving a lot of time. So with data collection, I usually budget about an hour because I really want to talk to the patient. From there, the digital wax process can take about 3 hours in total from start to finish, not continuously. I never talk to anyone for 3 hours about anything. And then from there, fiduciary markers, if you use them, will take about 5 minutes. And 15 to 20 minutes for the scan itself, because you have to seat the scan bodies, do the scan, put the patient in white caps, and do the white cap scan. So it's 2 parts. Then there's the prosthetic design, which takes about 30 minutes to turn over if you work with a great lab. Then you go through the print process. And currently, these are roughly the print times that I'm seeing clinically. So just about an hour. And then, assuming everything is done well, when you insert the restoration, it drops right in. Passive fit, occlusion might take 30 seconds, and you just have to torque the screws down. And that's the reason why I would budget 5 to 10 minutes, because they don't really want to send patients home with open access holes. So 120 minutes. With a pre-treatment baseline, we always start with clinical photos to identify the smile line, identify chief concerns, take intraoral scans, get informed consent, and coordinate a surgery date. How long or how many visits would it take you if you had to make a denture or an immediate denture conventionally? You don't have to say any real numbers, but the reality is that most people will take at least 2 visits if you're working with alginate impression, or up to 6 visits if you want to go through a whole try-in process, right? But now you do a digital design, we can boil it down to just 1 visit, because as long as you have the design on file, we can turn it into anything. So from there, I'll usually plan everything on DTX as much as possible so that we have an idea of where the implants need to go. In this case, this is actually a zygoma patient, so you only see 3 implants planned. But what it allows us to do is actually determine which implants we need to have in stock for the surgeon and which MUAs or prosthetic components I might need that day. And that way, it helps us consolidate our inventory order and make sure that we have everything we could possibly need. So after we have consensus on how to proceed, the patient will proceed with scheduling a surgery. I'll have the lab send me back a design. In this case, I asked for a replica of the existing denture. And I, at that point, create what I call the printed surgical starter pack. So we start with a reduction model. If the surgeon wants some kind of visual guide, we'll make a reduction guide out of surgical guide resin, an MUA positional guide if they're freehanding, and they want some idea of how our MUAs are seated in the implants. We'll make a wash denture just in case that we ran out, our fiduciary markers didn't work out. And lastly, what I call the emotional support denture. So the emotional support denture is also printed based on the same wax that you'll see all 4 of them are identical. And it's really there if for some reason something goes sideways and we can't load the implants for whatever reason, or if it really comes down to it, we need to send the patient home in a denture. After that, we start surgery. Usually with surgery, there are 3 different types of fiducial markers that we'll choose from. One is teeth, one is fixed artificial markers, or we might have none. There are issues that can come up with either of them or all 3 of them. When we have teeth fiduciary markers, what you'll find is that that means the surgery has to occur around whatever we chose to keep. What problem do you see here for this surgery? It might actually extend their surgical time because now we're doing a stectomy twice to get the same outcome. So it actually gets in the way of surgery for sometimes. The other one is the one where we choose to tack on some kind of artificial marker, whether it's a white cap or a custom plate. The issues that arise here is that, one, you have to do a rescan right before surgery starts. Not a huge issue. However, what happens is that if either of these were to move during surgery because someone was too aggressive reflecting a flap or so on and so forth, this data is no longer useful. And the problem when we have none is that, I'll show you shortly, if we don't have any kind of data to relate back to the patient, now we just have floating implants in the air that don't have anything to do with the patient. So when we have none, there is a workaround, and I will show you just shortly after this. So again, when it comes to teeth, they must be determined and agreed upon prior to surgery, because basically it might get in the way of surgery, and also we cannot extract or move these either. So it requires a minimum of 2 to 3 teeth, a minimal mobility, ideally across the arch. And lastly, cannot be extracted until after the soft tissue scan. With fixed artificial markers, what you'll see is it requires a rescan prior to starting, again. Markers might not be moved or movable, and they may also interfere with the flap. So you have a zygoma patient, and for whatever reason, you need to reflect the palatal flap more. That might change your outcomes. And lastly, when you have none, what will happen is that it requires a quick set wash impression using an existing denture or the denture monolithic denture wash so that we can actually relate the patient's jaw back to the original wax-up. So here you'll see the denture wash impression being done. No different from trying to seat a denture for the first time. What you're doing is making sure that the occlusion's reasonable. Inject blue mousse. My choice is to use blue mousse because it doesn't rip out sutures. Make sure it's fully seated, and for bonus points, sometimes I'll take a picture and send that to the lab technician. From there, you scan the entirety of the denture so that they can merge it back into the original wax-up pattern. based on the original teeth setup or whatever markers are available at that point. But in this case, what you'll see is I'm scanning in a monolithic denture for the purpose of making sure that these teeth will actually merge back with the wax-up teeth in exocad. So at this point, what I'm doing is not relying on biologic markers, but straight up relying on my digital data being accurate. And from there, you can see the scan and where the white caps are. The important factor is not getting a perfect impression of all of the white caps. The most important factor here is reestablishing the positioning of at least 2 to 3 of these white caps back into where the teeth setup is on exocad. And what you'll see here is that I scanned the patient in occlusion as well, and the occlusion is completely off. The reason behind this is because the patient actually had a history of TMD and actually did not have a stable jaw position. And I found out on the day of surgery. So it was not intentional to make it look like that. At that point, you swap out the white caps or ICam scan bodies and complete the scan. This video is being done in real time. Upon seating the scan bodies, the scan itself takes about 50 images, so it's about 30 to 45 seconds from start to finish. And once we have that data, this is what it looks like. And that's the reason why we needed a soft tissue scan, or soft tissue relationship. What this camera does is basically generates the vector points of individual implant positions relative to each other, and you can transform them into anything you want so that it can merge back to the original file, or the soft tissue file. So here you can see I've done one transformation into ELO scan bodies, and then here I'm transforming it into white caps. And at this point, you can finally combine both of these data sets to create something like this. So what happens at this point is that we have a denture that's related to the original wax-up or digital design of the teeth, and we have these 4 implants that are basically floating in space. And here you'll actually see why having an extraoral scan or photogrammetry actually gives you a better outcome. So if I were to even scan an impression, what you'll see is that there's a little bit of distortion, but the positioning of the white caps here, because they're made of plastic, have different levels of distortion. And the more blue you see is more fidelity between the 2 data sets. So you'll see here that if we were to just rely on the denture scan and say, okay, let's convert that, you would have wound up with maybe 1 screw that's fully passive, and 3 of them would have been misseating. But with this data, it's sufficient to move forward with the design. And from there, we can actually merge the original denture setup that we made with the new implant positions. And what we did was use the patient's original bite reference in order to create the proper occlusal relationship. And what you're seeing me check for here is 1, what the implant abutment library they used was, because guess what? There can be errors there. Another thing I'm checking for are the prosthetic contours and ensuring that this is going to be hygienic and have a nice, gentle seat. How many of you have experienced putting excess pressure on gingiva on the day of immediate load? If you haven't experienced it, what happens is that sometimes when we do a conversion, we're hardwired to try to connect all the implants and make the intaglio flat or convex. The problem is that sometimes it'll interfere with the ability for the tissue to go through sufficient or passive healing around it. So if you put excess pressure on it, what happens? Sometimes nothing, sometimes bad things. So from there, you get your restoration back. And this is also in real time. This is how quickly you can nest a design at this point. And I have my own little ways to go about it, but this process takes about 2 minutes. And then you can send it off to print. What I'm doing here is making sure that I don't have any automated supports around any of my screw access holes. And moving forward, this is how fast cleaning is. And this is usually where I get involved, or if I'm not on site, I'll send a lab in to do the post-print processing. So for a lot of printer systems out there right now, the supports are quite strong. With Sprint Ray, it's actually pretty easy to peel off. It's almost like peeling shrimp. It just pops off, and you can go ahead and clean it. What you're seeing is that I'm also not immersing this in alcohol because that will actually weaken the structure. Moving forward, we do a 17-minute time attack where while I'm waiting for things to cure, I clean the op, set out restorative kits, or make sure that everything's turned over, make sure the patient's happy, or just do anything else. Go check email, look at your phone, I don't know. But the final curing process takes 17 minutes to reach maximum curing. If you're in a pinch, you can put it on the 5-minute curing setting, but it won't have the highest degree of conversion. And this is how we can finish. What you're seeing is that basically I've retitled myself as a micromanager across all these slides, because at this point, I hope you're seeing is that all this heavy lifting was done at the very beginning of the case. All I'm doing is basically going through every motion with everything already planned out on my end. The only variable that I'm really working around is how the surgery goes and where the implants are placed. So these are just a few examples from local labs, and what you'll find is that when you have a dialed-in completely digital workflow, you can work with anyone and be able to get pretty good results. Because what happens is that when everyone's using the same design software and you have the ability to evaluate the work ahead of time or make minor adjustments along the way, the adjustment times are much faster. And also what happens is that all the labs are able to do better work. In order to go to finish from here, we're looking at a similar workflow where we start with a new baseline where we accept that on the day of the initial ICam scan, there might have been some changes. We still need to do a new soft tissue scan because the soft tissue would have remodeled at this point, and we finish with photos. From there, we move on to a new design. I usually try not to do it on the same day. I give the lab plenty of time to mess around with the design. That way I can evaluate and suggest changes prior to committing to a print. At that point, we can bring the patient back in to do a try-in, take new photos, diagnostic scan, and once a patient's happy with their outcome, we can do a one-to-one in zirconia. Because guess what? With ceramic reinforced resins, we can design this try-in to be anatomically and intaglio-wise identical to the final. So we're at this point in time where we can literally just copy an existing printed restoration and go, let's just take this to zirconia. This is a massive game changer for FP1s because now you can actually have full control of the soft tissue surface and predictably do it. Oh, sorry. So what happens is that if you look at the actual clinic flow, it doesn't take much from start to finish. Still, the longest time you're going to take is at the beginning, where you're talking to the patient about what changes that they want to make. And from there, all this is passive. And the next time you see them, the restoration will drop right in, because there shouldn't be any real adjustments. And assuming that they're happy, the final zirconia only take 15 minutes, because everything's dialed in again. So what brought me to using the Procera framework was two things. One being that I was trying to figure out how to get rid of that junction between the tie base and the zirconia restorations I was inserting, knowing that we have very limited control of three-dimensional shrinkage. So this is actually a complication I handled in the past year where when a lab tries to mill and sinter its own zirconia, even with perfect data sets, such as implant positions, we don't have control of sintering shrinkage, so you wind up with chipping and misfits that way. So imagine going through this entire process, making sure everything is within 5 to 10 microns of perfection, or accuracy, and then ruining it all because you decide, okay, you know what, I'm going to mill my zirconia, and I'm going to sinter it, and I have no idea which way it's going to shrink, and create all the misfit that way. So after I saw a couple of patients like this, where we didn't have a tie base, I decided, okay, you know what? I'm going to have to move forward with something more reliable. For those of you who go, okay, well, we could just use a tie base and cement it in there, what is the margin of error you're inducing when you're trying to insert or cement each of these tie bases into the full arch? You can look at plenty of studies that show, oh, it could be as small as this number or as big as that number, but the reality is that there is a number assigned, and it's big. So when you look at the material science behind the new zirconia framework that just came out, it's actually really nice. This, I believe, came out just about a month ago. And now it's multi-layered, and they have a better control of shrinkage, and it actually comes with a magical 10-year warranty. So again, why cement-free bridge? Because we don't want to deal with debonding, even as a result of the slight misfits. We don't want to deal with any kind of additional complications, and we want to basically make sure everything is as passive as possible. So again, it takes us back to tolerance stacking and what we're trying to accomplish. We're trying to get it down to a passive fit of 20 to 35 microns. If you look at most papers right now, they'll tell you that passivity is 150 microns, but the reality is that we don't actually know what that number is. But if you do enough all-on-4 restorations, the idea is that you want that number as close to 0 as possible, because every time that there's a number that's exceeding the magical unknown number, we wind up with more complications. And the great thing that comes along with it is a 10-year warranty, but they have 4,600 patients they've already tested this on, and it's been working. And that's why they extended the warranty, and I thought, okay, this is great. I'm going to try it out. So I had this patient that came in after healing, and you can see that we actually did a little additional surgery on one side, but took photos, intraoral scan, extraoral scan. I tell the lab exactly where I want to move the teeth and where I need added tissue pressure to compensate for certain things I was seeing in the picture, such as, oh, well, this tooth looks a little short. Let's increase the tissue pressure, change the pontic shape a little bit. And here, we just extracted a tooth, so I'm going to have to fill that back in, because they actually kept a tooth for the provisional. This is how the patient healed. Took a new ICam scan on the same visit. And from there, we print a new try-in. So what you'll see here is that we've designed everything as closely as possible to what we would want in zirconia. And you can also see here, I have the ability to go, okay, lab, what is with this? Fill it in, giving you a nice gooseneck there. It gives me the ability to evaluate the design in my hand and also see how it looks on the patient. But you can see also how nicely everything prints out now. This also gives me the ability to see the patient's tolerance of a monolithic restoration, because when you print anything, it's all one resin. Seat it in. I promise you, I did not want to give the patient this shade. This is what the patient really, really demanded. But you can see that now we have full control over where additional tissue pressure was needed and compensate for any shortcomings that we found in the provisional stage. And this is how it looks. The patient went on vacation for 3 months and swore that she didn't eat anything hard. I can promise you she probably did, but you know what? It survived. Once the patient's satisfied with that, all I had to do was scan in the surfaces and identify where occlusal changes might have been made. And we just redesigned everything in for zirconia manufacturing and had it fabricated. So what you're seeing here is actually the zirconia framework from Procera. This is the old one, too. So what you're finding is that even with the old framework, it is possible to get great outcomes, because I've heard enough complaints about that. It doesn't come out great as long as the lab knows how to work with it. But with a new framework, it looks even better. Because look at this. This is what we received back in the mail. And what's nice is that for any areas where we had angulation issues, the new screw that comes with Procera frameworks actually allows us to compensate. But you can see the finish, you can see the intaglio surfaces, everything's really, really idealized. This is how the patient finished. So this is, again, monolithic zirconia. This is the older version, but we still got great results. She loved it. I promise you, I did not select this shade myself. The patient really, 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 really wanted it. It's a little bit bright, but it looks great on her. In terms of the dental technicians that were featured in this slide set, includes pretty much everyone local to Greater Seattle. And what you're going to find is that no matter who you work with, the outcome is very, very nicely controlled now because we have control of the entire process and we can actually trace where errors occurred. If you're interested and you happen to live locally, these are the labs that all have an ICam at this point, as far as I know. As for myself, I actually bought my own and drive around with it because sometimes the labs are not available, and if you do enough of it, it actually makes sense to have one. And on that note, I thank you for going through this workflow with me today. I was just trying to narrate from start to finish how things work. If you have any questions, please feel free to ask.